So our next speaker is Dr. Vignesh Murthy, who has traveled around Canada quite a bit in his training. He started, did a bachelor's in McGill and went to medical school at McMaster, then completed his family practice, family medicine at the University of Toronto and internal medicine at the University of Saskatchewan. All right, so 4. And then finally he did a fellowship in adult hematology at UBC, and he's still here. He's doing a specialty. He's the first Naaman Vickers Endowment Fund fellowship trainee in classical hematology. This is a program established by Haley Merkley and Shannon Jackson, and this is a focus on bleeding and red cell disorders, and we're really pleased to have you here. Take it away.
Okay. Hello, everyone. Thank you for inviting me to speak to you all about iron overload and thalassemia. Thank you to Ritika for starting off and giving me a much easier job explaining what this means for patients. And thank you to Dr. Conway for that lovely introduction. So we'll get right into it. Acknowledge that I'm presenting to you from the ancestral and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no relevant disclosures. And so thalassemia in brief. So hemoglobin is the most common form of hemoglobin in adults is hemoglobin A, composed of 2 alpha and 2 beta subunits. And so those are produced by 4 alpha globin genes on chromosome 16 and 2 beta globin genes on chromosome 11. And so thalassemias are a heterogeneous group of disorders resulting from deletions or mutations in some or all of these genes, as well as others, which I won't get into today. But the bottom line is that when you have a number of these genes affected, you have an imbalance between alpha and beta globin gene production, and you essentially have a quantitative problem. You have too little hemoglobin. And so what does that look like in terms of clinically significant diseases? We have a smattering of thalassemias. There's a whole spectrum of disease from mild, clinically undetectable to much more clinically significant. And so I've highlighted some of the clinically significant entities here, which are reflected in the deletion or mutation of most or all of the alpha or beta globin genes. And so what does this mean for a person practically speaking? There we go. So clinically significant thalassemias manifest as severe transfusion-dependent anemia or as sort of more moderate anemia that becomes dependent on transfusion temporarily in times of infection or stress. But it's a multi-system disease. It's not just about the transfusions or the anemia. Thalassemia is characterized by iron overload, which I'll get to in my next section, osteoporosis, and then a number of other end-organ manifestations either related to anemia itself or due to hemolysis. So it's a significant multi-system disease. And so these patients, most of them in BC, are followed by the provincial red cell disorders programs. And so that's St. Paul's for the adults, and that's at BC Children's on the pediatric side. And so as far as iron overload in particular, so thalassemia has a complex process of iron overload, but the bottom line is that underlying it all, you have this process of ineffective erythropoiesis, either because you have an imbalance, you have too little alpha globin or too little beta globin. What happens is that your red cell production is ineffective, or ineffective erythropoiesis. And so the bone marrow and red cell precursors respond to that by releasing a variety of hormones, including most particularly erythroferrone. And so erythroferrone goes to the liver, it goes to the gut, and it causes upregulation of iron absorption and increased iron storage. And that's because the body it's smart, it tries to deal with the anemia, but unfortunately, as far as it's concerned, most anemia is iron deficiency, or at least this kind of anemia is iron deficiency, and so it responds to that stimulus by trying to increase iron absorption. But as you might have guessed, iron is not really the problem in thalassemia. These folks have a genetic deficit in their globin genes themselves. And so what that means is that patients experience both increased gastrointestinal iron absorption and transfusional iron loading. So that ineffective erythropoiesis causes production of erythroferrone, which then drives increased intestinal iron absorption. The average person, for reference, absorbs something like 1 to 2 milligrams of iron through the gut every day, and that's balanced out by 1 to 2 milligrams of iron lost per day through the shedding of the GI tract. In thalassemia, the absorption gets doubled or even tripled. And so over the course of a year, if you just do some math, that daily absorption times 365 days, that's 1 to 2 grams of iron per year that they take on in addition to what they already have. Transfusions, well, the average unit of packed red cells contains 200 to 250 milligrams of iron. Our patients can require anywhere between 20 and 50 units of red cells a year, and as Ritika was alluding to, that's kind of appointments every 4 weeks, 3 units of blood, so 13 times 3 is about 36 units a year. And so that can translate to 5 to 12 grams of iron per year. For reference, a healthy adult has something like 4 to 6 grams of iron total in terms of total body iron stores. So people with thalassemia double, triple, quintuple that very quickly, especially if they're transfusion dependent. And unfortunately, that does not turn them into Iron Man or Iron Woman. It results in iron overload. And so where does this iron go? The body has a limited capacity to store iron safely. And so when iron exceeds that, you get what's called non-transferrin bound iron, or NTBI. And that iron can cause reactive oxygen species and organ injury, in particular to the endocrine organs, the pancreas, thyroid, pituitary gland, the liver, and the heart. And so that results in endocrinopathies, liver cirrhosis and hepatocellular carcinoma, and cardiomyopathy and heart failure. So serious complications. What do we do about it? Well, in addition to all the other treatments patients have to undergo for their thalassemia itself, they need regular lab and radiographic monitoring, so that's annual MRIs, that's regular blood work to monitor their iron status. They need medications to treat iron overload, either by mouth or subcutaneously. Those medications are called iron chelators. They bind and allow for the excretion of iron, either renally or through the gut. But those medications also have side effects, and so those side effects require additional monitoring testing for audio toxicity, renal toxicity, ocular toxicities. And so thalassemia is a burdensome disease. Ultimately, what I want to impress upon you is that transfusion-dependent thalassemia is a really burdensome disease. It imposes a lot in terms of appointments and tests and treatments. And so it is our hope that through research we can ease that burden. And that's where the final section of my talk comes to, and that's the transfusion-sparing therapies that I hope to discuss in forthcoming slides, namely, in this case, luspatercept. So what is luspatercept? It's what we would call an erythroid maturation agent. And the reason for that is, although the precise mechanism of actions are not fully understood, in all honesty, it is thought that this pathway, the TGF-beta pathway and the SMAD2 and 3 downstream, that signaling, are implicated in models of ineffective erythropoiesis, seen in MDS, seen in thalassemia. So what luspatercept does is it binds the TGF-beta and prevents this signaling. And thereby, instead of those red cell precursors getting destroyed, in theory, they are allowed to mature, and so you have a reduction in anemia and a reduction in ineffective erythropoiesis. And so BELIEVE study in particular was a phase 3 trial of luspatercept in patients with transfusion-dependent thalassemia, and sort of the main evidence justifying its approval for this indication. And so it evaluated luspatercept against placebo in patients with transfusion-dependent beta thalassemia. 336 patients were randomized 2-to-1 to receive luspatercept or placebo for a minimum of 48 weeks. And the primary outcome was the proportion of patients who experienced a 33% reduction in their transfusion burden. And so as you might surmise, if someone's getting 36 units of blood a year, cutting that down by a third that's 12 less units a year. So that is a clinically meaningful outcome. And I'll get right to the results, and it found, and BELIEVE anyway, that around 20% of patients on luspatercept, compared to something like 3 to 4% in the placebo arms, had met that outcome of a 33% reduction in their transfusion requirement over this pre-specified 12-week periods at weeks 13 to 24 or 37 to 48. Of note, if you looked at any 12 or 24-week interval in the trial, those numbers changed. It was more like 70% of patients had a response to luspatercept compared to 30% in the placebo arm. Some patients even experienced a 50% reduction in their transfusion burden. Much smaller amount, but again, something like 7 to 10% of patients on luspatercept had their transfusion requirements cut in half. The adverse effects were bone pain, as Ritika mentioned, arthralgias, so joint pains, dizziness, hypertension. Less common but severe adverse effects that we watch for now are thrombosis in around 3% of patients, although the caveat being that that happened in patients who had other risk factors for thrombosis. Post-marketing surveillance has also identified a risk of extramedullary hematopoiesis in patients receiving luspatercept. So that's something we watch for now as well. So in summary, luspatercept offers clinically meaningful benefits, translating to something like 6 to 8 less units per 6 months or 12 to 14 over a year. And that could mean shorter appointments for transfusions, fewer appointments for transfusions, less transfusion-associated adverse effects, and of course, the resource utilization savings in terms of our blood supply and nursing and chair time. Limitations, of course, only 1 in 5 patients responded, and so it's not a universally applicable treatment. And of course, there's concerns with these adverse effects, including thrombosis and extramedullary hematopoiesis. So in summary, the thalassemias are a heterogeneous group of conditions resulting from quantitative defects in hemoglobin production, what we describe as too little hemoglobin. Iron overload is a common and serious complication in both transfusion-dependent and transfusion-independent patients with thalassemia, and it causes significant morbidity and mortality. And novel treatments, including luspatercept, which reduce transfusion requirements and improve patients' quality of life, are really important and necessary. And we hope that development will allow for more to come in the future. And that's all I have. Thank you.
Hello. Hello. Hi. That was a really great talk. It was great to learn some more about beta thalassemia. I just wanted to ask, I know Casgevy is a relatively new gene therapy that can be used for these kinds of indications, but in Canada, what's the access like to gene therapy like that, and how do you see a therapy like that impacting treatment?
That is a great question. So at this point in time, Casgevy is still, and products like it are still going through the Health Canada approval process. And so once that happens, once Health Canada approves the medication, what needs to happen is the national funding body called CADTH needs to decide whether it's a cost-effective treatment to fund, and then it needs to go to the provinces to decide kind of how it's paid for, who would provide it. Unfortunately, gene therapies are, at this point in time, relatively intensive therapies, requiring at least to some extent an autologous stem cell transplant, so they need to be delivered at a bone marrow transplant center. So that requires additional kind of resource mobilization. So I think there's a lot of promise. The studies have shown significant reductions in patients' transfusion requirements, but at this point in Canada, I don't think I wouldn't say they're readily available.
Thank you so much for that wonderful body of work. I just have a question regarding, so you mentioned that 1 in 5 patients have that benefit of 33% reduction. Did you see it? What proportion of patients even had like a 25% reduction or even a 10% reduction? And would you consider this clinically meaningful? And if so, do you think that that would be worth the cost-benefit analysis of this therapy?
That is also a very good question. I think, so the reported data, they really only reported the 33% and the 50% parameters. They didn't actually report whether people had lower increments of response. In terms of whether it's clinically meaningful, I think certainly a 25% might be clinically meaningful. 10% maybe less so, because this is a medication that requires its own appointments for administration. It's not something people can kind of get at home. So I think there's trade-offs there for sure. If that answers your question, yeah.
Yeah, I'm just wondering if it would be possible in the future for it to be like a home self-infusion medication rather than a in-hospital to decrease that burden.
I think that's always the ideal. I think that's always the ideal, but
pharmacist, I can speak a little bit to this. The reconstitution process takes about an hour of pharmacist technician time. So the manufacturer would need to produce a pre-filled syringe, and it's a weight-based medication, so they'd have to produce a variety of syringes and then allow patients to basically round to the nearest syringe size. So there's logistical barriers, I think, that create some challenges. It's also extremely expensive and currently very tightly funded and controlled through PharmaCare and the Manufacturer Assistance Program. So, I mean, I would love to see it be available for patients, but I think there would need to be some significant logistical barriers to overcome in order for that to happen.
And just to add to your question about the lower reduction in transfusion burden, so yes, there is benefit for patients even with a lower reduction, but PharmaCare is absolutely rigid in what they will approve, and so even if you're 32%, that's not going to meet their criteria. So we have to sometimes intentionally under-transfuse patients, and they have to live at like a slightly lower hemoglobin until the PharmaCare renewal process resets, so that our patients can continue to have access to this medication.
I just wanted to comment that most of our patients have the drug the same day that they have the transfusion. So it's not two different appointments. We do it on the same day. So kind of helps.
thank you.